Along the glaucoma therapy continuum, Joe Panarelli, who runs the glaucoma at New York University, is going to talk about management of cataract and glaucoma and the role of MIGS.
All right. Well, thank you everybody for being here this morning, and thanks to the organizers for the invitation to speak. And so I took the liberty of sort of fiddling a little bit of the topic and really just talking about cataract surgery in general and how we approach it as a glaucoma specialist. And I will touch on how MIGS sort of fits into my treatment algorithm. I actually love Tony's last slide there about sort of how we look at sort of the treatment algorithm for glaucoma. And really, it's amazing how much it has changed over time. I think one of the biggest challenge, though, is working, I think, together, ophthalmology, optometry, and really getting these patients early in the disease course. And that's often really where the challenge is. So many of the patients present with more moderate to severe disease, and therefore it's hard to work that algorithm if we're sort of jumping in kind of in the middle there. So kind of ties a little bit into cataract surgery as well, and sort of how my thinking has changed kind of over the years. And so financial disclosures, again, I don't think they'll have much relevance here because for the most part, I will be saying how I don't use a lot of these devices. So approach to cataract surgery in the glaucoma patients. So I think there are two things to consider, big things, of course, your pre-op, and then you have your post-op issues. So pre-op, I think we always have to have a good discussion with patients about the amount of visual field loss they have and how that may be not necessarily impacted, but how it may become more relevant when they have cataract surgery. There's this big question about always offering MIGS, and if you go to any glaucoma meeting, this occupies maybe 2/3, I feel like, of the surgical days that we have, and really, there's no answer to it, because if there was, we wouldn't continue to debate it at every single meeting. And then when do we combine cataract surgery with the more traditional surgeries, which I think, looking around the room, I know there's a lot of us here that tend to be on more of that other end of the spectrum, where we're seeing, we're the tertiary referral center, where we're getting patients who have more advanced disease on multiple medications. And I think we really will look at cataract surgery a little bit differently for those patients. And there's the post-op considerations, preventing IOP spikes. I think nothing is sometimes more upsetting to a patient than coming in on the first day and you're telling them how good they're seeing and they hear how high the pressure is. There's, of course, concern for further optic disc damage. How we manage the IOP spikes, not just early in the, on that day one period, but, in that first week or first month, and then what to do with our blebs and our tubes afterwards. And so pre-op considerations, again, these are the three I'm going to kind of touch on here. And, to begin with, so visual field loss. I think this was something that I didn't learn in my training, and really was kind of humbled to sort of hear from some of my patients at times about how really, I set the bar so high for how good they were going to see after cataract surgery. And, they came out of the procedure and really just had this look on their face like I sold them something that I shouldn't have. And so, I become more careful, I think, over the years about, really going over with patients what their visual fields look like and how they will be, they may be more noticed after they have that cataract removed. And I don't know why that is the case. And I don't know if anybody has thoughts on that, but I don't know if it's some neuroadaptation, but it is amazing how patients will sometimes come out of the cataract procedure and say, I didn't have that there before. And, you'll go back and show them the field and they'll be like, yeah, but I didn't see that before. So I think it's very important to really show the patients the fields and sort of let them know what they may or may not expect. And I think it's always better to set that bar kind of low and exceed their expectations. Looking at the other eye, I think that's so important. There are definitely times where if I have a patient who needs bilateral cataract surgery, I may even start with the better eye first, because there have definitely been plenty of times where the patients start with the worst eye, do not get the outcome they thought they were going to get, and then become hesitant to have surgery in that better eye. And that's the eye that they really need to maintain their function and their independence. So, I think these are things that really are important to consider pre-operatively. And that really starts, and that takes a little more chair time. So I think before we're even going to the question of MIGS, of needing additional surgery, we have to sort of talk more about their vision, because that's why we're doing this surgery. That's why we're doing cataract surgery. All right, this is the big question here, and I'd love to actually just get everyone in the audience's opinion, but we don't have time for that. I will say, when I made a similar slide, I actually kept what's at the bottom there, and it's a poor choice of wording. I have here, I do not offer MIGS if the patient is at their target IOP. And so, that's the first question. Is the patient at or above your goal going into cataract surgery? And I will say, it's not that I don't offer. I probably would say I don't suggest, or I don't often recommend if the patient is at goal. So if a lot of my patients are at target, They've been doing well on their topical medications. You know, I'm somebody who actually does still believe in drops. I feel like they've worked for so many years, kept so many of our patients stable. And we've seen the power of cataract surgery. You know, in the control arm in so many studies, we've seen that cataract surgery does give a significant IOP reduction that does carry out for at least 2 years and maybe even longer in some patients. And so, again, I feel like I say that, but I don't disagree with people that want to necessarily do cataract surgery with MIGS to get some patients off medication. Because as we've heard this morning, medications definitely have effects on the ocular surface. And so if we can, I think, consistently get the IOP reduction that we want with a lot of these MIGS procedures for a sustained period of time, then I think it is reasonable to offer it with every cataract surgery. The problem I have is I really haven't seen enough data to really make me feel comfortable with that, or at least enough long-term data and comparative data against each of the devices or procedures that we have. The next thing is to look at the type of glaucoma and I think the severity of the disease. I will say for a lot of the secondary open-angle glaucomas, I am maybe a little bit more apt to consider certain types of MIGS procedures. Again, severity of disease, there is talk about doing microinvasive glaucoma surgery in patients with more advanced disease, but I don't believe it has a really good role there. I personally feel MIGS are really for those ocular hypertensives, mild, and certain patients with moderate disease. Always important to know what the angle looks like. I work very closely with my optometry colleagues, and we talk about, you know, which patients are really ideal for certain types of angle-based microinvasive surgeries. And I use MIGS often to talk about microinvasive glaucoma surgeries. Those are stripping and stenting procedures of the angle. We do have microinvasive bleb surgery, and I really sort of push that a little further down the line, and I hesitate to call those true MIGS surgeries. But for the angle-based surgery, you really have to know what the angle looks like to know if these patients are going to potentially do well. Patients that have some crowded angles, peripheral anterior sneaky eye, you know, things that probably are sort of telling you, please stay out of the angle. I think those patients are not really ideal for MIGS. Anticoagulation, this is the big thing, at least at NYU. We really don't stop anticoagulation for any of our glaucoma procedures or cataract procedures, just because based upon certain risk analyses, we found that there are more serious consequences to the patient's overall health. But it is something to consider when you're doing angle surgery because of the higher incidence of bleeding. Combining with traditional surgery. So now again, traditional surgery, the other end of the spectrum, we're talking about trabeculectomy and tube shunt surgery. So when do I combine my cataract surgery with these bigger procedures? Well, when the patient's above the target and they have moderate to severe disease. This is a big one, I think the second one, when they have advanced disc damage and they are very young. And for me, I would say that the severity doesn't always matter in these cases. I'm not a huge fan of kicking the can down the road. So if I have a 40-year-old patient who has, you know, a significant amount of cupping, whose father went blind at a young age, and they're on a number of drops, I will consider doing a phaco tube or a phaco trab in those patients. Patients at target with moderate to severe disease, but when they're on maximally tolerated medical therapy, especially if that includes an oral agent such as acetazolamide. So, you know, I may have said before, for patients with microinvasive glaucoma surgery, I don't always offer MIGS because I have other options. For a patient who has more moderate to severe disease, but is on maximally tolerated medication, if they spike after cataract surgery, we're moving on to those bigger procedures. So I will at least consider it. And I will say this, that in general, I do like to stage the procedures and do the glaucoma surgery first, especially when it comes to trabeculectomy, just because I did not do a lot of phaco trabeculectomies when I was a fellow. I actually did 0. So I learned how to do all of this afterwards, and I just find that I'm not as good at that procedure. And I really think that that's important. You want to do procedures that you're really comfortable with. So for me, a lot of these procedures I like to do first and then come back and live to fight another day. So in terms of post-op considerations, yeah, there's things you have to consider. And as I said, that day one IOP spike it's real. And I think for a lot of the comprehensive ophthalmologists out there and even optometrists, you see this and, you know, it's kind of like, does this happen? And I always say that cataract surgery is a great stress test for any of those patients who you're not sure if they have glaucoma or not. So you take an ocular hypertensive patient, go ahead and do some cataract surgery. They come in day one with a pretty solid pressure. These patients are probably going on to have glaucoma. And I think we often blame ourselves. We say it's retained viscoelastic, it's this or it's that. These patients have impaired outflow pathways. It's not shocking when they come in on day one with a spike, even though they went into surgery with a well-controlled IOP. And so, you know, I think the patient up top here, that left eye, yeah, that can handle a day one spike. I would say that the patient with the right eye visual field down below, that's not going to be so good. So there's different ways to deal with these spikes, and we'll sort of talk about that as we go through it. So day one spikes, they're going to happen. There are some things that we do intraoperatively, such as bringing down the pupil with MyoCol or MyoStat. There are things we do postoperatively. I routinely give my patients Diamox the night of surgery in the morning after to try to mitigate some of the IOP rises that probably occurred during that first night. But I think the most important thing, as always, you'll hear me say this over and over, is talking to the patient, letting them know that this is a possibility and that, if it does happen, we'll get them through it. I think the biggest thing is the shock to the patient, and this carries through for all of glaucoma. It's the sticker shock when it comes to medications. It's the visual acuity that they didn't really get that they were expecting to get, or it's, spikes in the pressure. So one thing you hear a lot about at glaucoma meetings is, when it comes to MIGS, is that, we talk about doing angle-based surgery to help prevent some of these day one spikes. And I think that's a big question, especially when it comes to doing, implanting devices, and I think it's hard to justify the cost of some of these microinvasive glaucoma surgeries solely to prevent a day one spike. If you're really thinking that you're going to give a patient, more sustained IOP reduction, I'm fine with that. But when people use that argument that it's going to prevent these day one spikes, I think the cost really just isn't there. We have other options. In terms of the IOP spikes, I think for, again, the optometry colleagues, a lot of times you'll see some of the early post-ops as we co-manage a lot of these patients. And it's a question of, man, what do I do on day one? Like, what is a safe pressure to send this patient home with? Well, it really does depend upon the degree of visual field loss and the degree of disc damage. But I think for the most part, a lot of these patients, I like to see them getting back down to a pressure in the 20s at least. And then when do you see the patient back? To me, the question's that's an easy one. I'm always seeing them back the next day, no matter how busy the clinic is, especially for some of these patients with, more advanced disease. You don't know how long it's going to take for them to get back to their steady state, or if this is going to be a persistent spike. So for a lot of these patients, I watch them very, very closely in the early post-op period. I tend to, put them on what I think is, appropriate therapy. Often it's an oral CAI for the first, 2 or 3 days until the pressure normalizes. I try not to throw the entire sort of kitchen sink at them if I don't think they need it. I think, again, I like this lecture because, it's all about, I feel the future is the co-management of glaucoma with ophthalmology and optometry. And I think, learning what to do and understand what can happen for some of these more complex patients who have, tubes and trabs is so important. And so, for a lot of patients who have filtering blebs, so those are trabeculectomy blebs or even Zen blebs, there's a lot of, preoperative and postoperative things that you need to think about. I think the first thing when you're going into cataract surgery for somebody who has a bleb, the first thing you really want to know is that bleb really functioning? And I think that's a thing for the glaucoma specialists, where sometimes we'll write in there low bleb, when really that bleb is not functioning. It's non-existent. And for those patients, you better expect that the post-op course may be a little more rocky. And so those are, some patients who you may need to think about doing an additional procedure. And so there's a lot of other things that we'll talk about in terms of using 5-FU, lots of steroids. For those patients who have a functioning filtering bleb, the one thing that can really destroy a really good bleb is phacoemulsification. Even a really good, efficient phaco can do that. In terms of tubes, not as much. They're pretty resilient. There's not as much in terms of intraoperative considerations as well as post-op. You can really manage these patients as you would manage, your routine phaco. But, the filtering blebs, I didn't spend too much time, but that's a whole lecture in and of itself of how you manage a bleb after having cataract surgery. Intraoperative pearls, I think, and I just kind of throw this out there because these are some of the things that the glaucoma specialists, this is what we're supposed to be really good at, these types of surgeries. So the short eye, we tend to get a lot of these patients. These are patients with an axial length under 20 millimeters. There's a lot of things that we think about preoperatively, whether or not we're going to give these patients mannitol pre-op. We talk about a lot of things intraoperatively that we have to be very, very careful with to avoid complications. There are certain prophylactic measures, I think it's a Zykes video where he does a zonual hyaloidectomy in every patient to prevent malignant glaucoma. But just suffice it to say that these are never routine cataracts. Patients with these short eyes, very thick sclera, these eyes can give us a lot of trouble. So I think that's a patient that you need to have a lot of preoperative counseling in terms of when is the best time for them to have surgery. Much like the next case where you have patients with pseudoexfoliation. Are these eyes where it's better to take the lenses out when, they're maybe not quite as mature, or do you wait a little bit longer? What is that ideal time? And that's hard. I don't think I have an answer to that. I think because phaco has become so much more routine for many of us, I think we are moving to doing these procedures in these more complex patients probably earlier rather than later to avoid complications. And so, these eyes with pseudoexfoliation for many of us, we take pride in doing these cataracts. These are a little bit tougher. These patients often need pupil expansion, often capsule support, and sometimes you have to do things with bag fixation, which I try to avoid, and I send to my colleague Manjul Shah, who's just much better at it. And the last thing we'll talk about is just sort of doing the combined procedures again. So I think For the glaucoma specialist, this is where really you're going to see how comfortable you are. And these are there's a lot of challenges when you're doing trabeculectomy and tube shunt surgery together. I probably won't go through all the pearls for the audience here, but I think we all know that these are more challenging procedures. Give yourself more time, especially if you're teaching. I think many of us in the room here have residents, we have fellows, and when we try to do these cases together, these are not easy. These are exhausting cases, and they're even exhausting sometimes for the patients. So, yeah, I think there's a lot to think about when it comes to cataract surgery as the glaucoma specialist. It's really not just as simple as, hey, the vision is X, it should be Y after the procedure. And I think much of this is stuff that I feel like I was humbled by, and I learned probably in the first 5-10 years of clinical practice, and I'm still learning to this day. So again, thank you guys for having me here, and look forward to the next few talks.